All right, so we're going to continue our discussion of ER findings. And again, this is geared towards the R1 and the R2 residents. So this is our next case. Let's see. Anybody see anything? Yeah, there isn't that much really just looking at this chest radiograph, portable view from the ER, kind of maybe some hazy stuff at the lung bases, but it's very soft, so nothing really definitive. And so the patient goes for a CT of the chest, and here's what the CT shows. So what do we have on the CT? Is CT normal?
Bilateral ground glass opacities.
Yeah, so we have these patchy bilateral ground glass opacities. So what's the differential? So what could this represent? So we could have atypical pneumonia from what? Well, COVID, right? Something that we went through. COVID, viral pneumonias, sure. Anything else in the differential for patchy ground glass opacities like that?
Pulmonary edema.
Pulmonary edema, do you like this for pulmonary edema or not?
No, because it's more left-sided. It's not really symmetric, it's more like left-sided. Pulmonary edema would be more, I guess, symmetric on both lungs.
Anything else that goes against pulmonary edema?
No interstitial.
Yeah, we don't see any interlobular septal thickening, right? So you like to see some interlobular septal thickening. Anything else?
We don't see any effusions.
Yeah, we don't see any pleural effusion. I guess an acute inhalational exposure. So any kind of acute inhalational exposure, like smoke inhalation could do this. Could have this, theoretically with an acute hypersensitivity pneumonitis can also give you this kind of patchy appearance of ground glass opacities. You mentioned pneumonia, right? So these days we have to think of viral pneumonia and COVID pneumonia. Is there any other type of pneumonia we should consider? Especially in Newark. What other atypical organism can present as ground glass opacities on the chest radiograph? Well, don't see that too often here, but pneumocystis, right. So you would advise the ER to do what? Test for HIV. Yeah. So this was pneumocystis pneumonia. So that is something that you do have to consider for atypical pneumonias presenting as ground glass. Now here's a patient who's HIV positive who presents with fever, and the chest radiograph looks like this. Is there anything here that we would want to discuss?
Looks like there's cavitary.
Where? Yeah, so over here, maybe here, possibly also over here, right? So what are you thinking about? Septic emboli, TB, necrotizing pneumonias, right? All of that is in the differential. And here is the CT scan on this patient. So what does it show?
So you have bilateral cavitary lesions, air fluid levels.
Right, we have these bilateral cavitary lesions with air fluid levels. So what do you suspect that this represents?
Septic emboli.
So you would suspect septic emboli, right? Especially given that kind of peripheral distribution of some of these. Now take it to the next level. Is there another finding here that you'd want to discuss too?
Looks like there's see the, right?
Okay.
Tricuspid valve.
Yeah, so right here near the tricuspid valve, there's this subtle area of decreased attenuation. What might that represent?
Vegetation.
So then you put the story together as what?
Tricuspid valve endocarditis with septic.
Tricuspid valve endocarditis with septic embolism. What causes tricuspid valve? What can predispose to tricuspid valve endocarditis then?
I think drug use.
Sure. So what would you recommend for this patient? What's the next test you would recommend here?
Echo.
Echo. Yeah. And so there is this large vegetation here on the tricuspid valve. So that was a patient with vegetations and septic emboli from tricuspid valve endocarditis. All right. There is another patient who's HIV positive, has fever. In the chest x-rays, not much to say, questionable hazy opacities, but very, very hard to definitively come down on anything. And so it's not unusual in these cases for the ED to ask for CT scan of the chest to work out what's going on, right? So you should have a low threshold for doing that, and it's surprising the abnormalities that you can see on the CT that are very difficult to actually see on the chest radiograph, on these portable chest radiographs that we get from the emergency room. I mean, you're really hard pressed to say that there are definite cavitary lesions here. Maybe something there, but it's hard to say. But here, very obvious that we have these multiple cavitary lesions, peripheral distribution. This is another case of septic emboli. Okay. What about this case? What do we have here?
Local consolidation of the right middle. Pneumonia.
What's that?
I guess I could say right middle of pneumonia.
Well, first of all, what lobe do you suspect it might be? It's kind of high for right middle lobe. Right? So we have this large lucent area, and what is this? Air fluid level. So what do you think this represents then? Pulmonary abscess, right? So you have a necrotizing pneumonia with a large air fluid level, especially given this history of fever and cough. So you would think about an abscess. Here's a lateral view that again nicely demonstrates this air fluid level here, right? Now certainly with cavitary lesions, neoplasms can also be the differential for cavitary lesions, but with a history of fever and cough and a large cavitary lesion like this, an abscess would be the first thing you might think about. Right? This is in the right middle lobe. We have this large cavitary lesion here with air fluid levels, the surrounding consolidation. So this was a necrotizing pneumonia with an abscess here in the right upper lobe. Okay. Here's a patient who presents with fever and chest pain.
There's a substernal fluid collection with gas. It looks like they've had a sternotomy, so I don't think it's like an abscess.
Okay, so there's this substernal collection with gas. Patient has had a sternotomy, right? And what's happening here at the sternotomy site? Yeah, there's dehiscence there. So the history you don't always get is that this patient did have a sternotomy fairly recently, developed an infection. Here we have dehiscence. So this would represent what? Abscess mediastinitis, right? And we also have the pleural effusions, of course. Okay. What about this? Was that a normal or abnormal chest radiograph? So what's abnormal?
Could just be giant. You see the air monitoring.
So you think it's just airspace disease, or is there something else also going on there? Okay.
Coughing over.
So could be a large pleural effusion, right? So if you think there's pneumonia, if you think there might be an effusion associated with that, what are you thinking about?
Paramnemonic effusion.
Just a paramnemonic effusion or something worse?
Malignancy?
What?
Malignancy?
No, you have history of fever and cough. Fever and cough, large effusion, you're concerned, empyema is what you're concerned with. So you would recommend what?
CT.
Yeah, so anybody who you suspect infection who has a large pleural effusion, you have to be concerned about empyema. And we want to work that up with CT. So what does the CT show?
Left loculated effusion.
Yeah, so we have this loculated pleural effusion on the left side. Is that consistent with empyema? Yeah, certainly, right? We do have some pleural thickening and enhancement also. What are these spikes here? What's going on here in the lung? Why does it look like this?
Relaxation atelectasis.
But what are the spikes? Why is it spiky like that? Those are adhesions, right? So empyema, you can have a septated collection and the patient develops these adhesions. So it gives you this appearance on the surface of the lung from these strands of adhesions. Here too, there's adherent lung, okay? And then we have some consolidation here within the lung also. So this is a patient who had pneumonia and went on to develop empyema as a complication of their pneumonia. So loculated collections, septations like that, adhesions along the surface of the lung, all of that is consistent with empyema, right? Here's another patient who has a fever and cough. The abnormality on the chest radiograph is so what do you think that opacity represents? Yes, so, well, which is it, pleural effusion or atelectasis? Okay. So why do you think it's pleural effusion?
This is curving upward.
Yeah, it seems to go up. It seems to get denser as you go towards the chest wall laterally. Those are signs of pleural effusion. Certainly there's, you would suspect that there might be some underlying problem there in the lung parenchyma, like pneumonia or atelectasis. But again, with pleural effusion in somebody you're concerned about infection, the complication you're worried about is empyema, right? And so here's the CT. And so the question is, why is there air in the pleural space? Yeah, usually gas-forming bacteria doesn't give you a large pocket of air like that, right? So bronchopleural fistula is what you think about. In most cases, they're really alveolar pleural fistulas. So what happens is that there's pneumonia in the lung or consolidation in the lung, necrotizing pneumonia that breaks through into the pleural space, and some air gets into the pleural space. And it can give you an air fluid level like that in the pleural space. Many times the communication closes spontaneously. So we don't actually visualize the actual communication. It's unusual to actually see the communication on the CT, but we can see that there's air in the pleural space, so there had to be some communication. It's kind of subtle on the chest radiograph, some lucency here that turns out to be the air, but it's really hard to tell from the chest radiograph. So these alveolar pleural fistulas or bronchopleural fistulas, it's another complication of pneumonia that can lead to empyema. And then here also we can have air within the pleural space. What about this case? So what are you thinking about here? Yeah, so here we have this almost complete opacification of the left hemithorax. We talked about whiteout before. the mediastinum is shifted away, so you suspect that this represents a large pleural effusion. So within the ER physician orders a non-contrast chest CT. What are you going to do? Why? What's your differential? What do you think that might represent? How would contrast help you in terms of figuring out what's going on?
Well, I mean, if it does end up being a large pleural effusion, then it would be able to tell if there was pleural enhancements inserted up in my email.
Yeah, so with large pleural effusions, the two major things that you think about in terms of differential diagnosis, one is empyema. What else?
Underlying mass.
What's that?
Underlying mass.
Malignancy, right? Malignancy. Around here, hepatic hydrothorax can also present as a large pleural effusion, but there you have some history of liver disease. So if you're thinking about malignancy, trying to diagnose malignancy or empyema, those are cases where contrast is very helpful. So again, the larger the abnormality on the chest radiograph, the more you're going to need contrast to figure things out. And so here's the CT on this case. What do you think? What's going on here? Well, the two major things on our differential were what? Empyema versus malignancy. So, which is it? Why? It is a multiloculated effusion. You do see adhesions. There is some pleural enhancement, but can you see all of those things with malignancy also?
Yeah.
So how do you differentiate malignancy from empyema? What's different about the appearance of the pleura with empyema versus malignancy? You have what? Do you get pleural enhancement with malignancy? Well, if you have a malignant pleural effusion, it's caused by what? No, but what causes malignant pleural effusion? It's pleural metastases, right? So if you have a large pleural effusion and you're thinking malignancy, you're trying to differentiate pleural metastases from empyema. So how are you going to do that on the CT? What will you look for? Nodularity of the pleural surface, as opposed to smooth pleural thickening. Smooth pleural thickening is associated with empyema. Nodularity of the pleural surface is associated with metastatic disease and malignancy. What do we think here? Smooth or nodular? Where? So notice here. So there's kind of nodular, it's asymmetric in terms of the degree of pleural thickening, also here. Okay? And then notice that there is some enhancement that seems to extend towards the mediastinal pleural surface. And so if there's enhancement of the mediastinal pleural surface, that also is associated with malignancy. So can you see where the tumor is? Yeah, you see all this stretching of the vessels. Here in the left lower lobe, there's a necrotic mass. See these lucencies in there? That's a necrotic mass here in the left lower lobe. Okay? So this is a patient with lung cancer and metastatic disease to the pleural surface, resulting in this large pleural effusion with these adhesions. And again, this came through the ER. Actually, in this hospital, I find that most of the advanced lung cancers that we see actually come through the emergency room. Right? Most of the cancers we see actually come through the emergency room. And so here's the CT scan on this case. You can see the large effusion. You can see the mediastinal enhancement, the pleural surface. It's not really smooth pleural thickening. It's somewhat nodular and asymmetric, especially there. There's a big necrotic mass. over there. You can see the distortion of vessels. Imagine what this scan would look like as a non-contrast CT, trying to figure out what's going on. Okay. All right. So another thing we do a lot of is CT scans for pulmonary embolism. So this is a normal CT, there's no P here. So what I like to do is follow the right pulmonary artery, come down to the interlobar, look at the segmentals, watch the branching out to the subsegmentals. So we'll do that on the right side, and then we go back and we scroll through, and then we'll do that on the left side also. Most PEs will go to the lower lobes, so you check the lower lobes, the interlobars, and the lower lobes first. Then after you're done with that, and you're satisfied, or always, you should also scroll upwards. Look at the upper lobe pulmonary vessels, okay? But I like to look at the lower lobe vessels first because those are the ones that are most likely to be involved with pulmonary embolism. So, any problem here? So what do we see here? Yeah, there's a large saddle pulmonary embolism. So you can see that the filling defect bridges the pulmonary artery bifurcation, that's a saddle P, and extends down into the interlobar arteries and the segmental arteries. So what happens is that these pulmonary emboli, these are casts of veins, usually from the lower extremity, lower portion of the body. So these are like strands of spaghetti or linguine that embolize to the lungs. So that's what we see. We see that string of clot going across the pulmonary bifurcation, and also additional filling defects extending down into the interlobars and segmental branches. Right? So there's your saddle embolism. You can see extension into the interlobar arteries and then down into the segmental branches of both lobes. And the reformatted views, of course, can increase your confidence whenever you're dealing with pulmonary embolism. So, of course, the obvious finding here is going to be these large pulmonary emboli. But besides that obvious finding, what other important observation do we need to make? So how do you know there's right heart strain?
Look at the flattening of the septum or the right ventricle to the left ventricle ratio.
So how do you determine that? Where do you measure it?
Valves.
Yeah. So you look at the level of the valves, the level of the tricuspid valve relative to the mitral valve. So the diameter of the right ventricle at the level of the tricuspid valve should be about the same as the diameter of the left ventricle at the level of the mitral valve. And they might not be at the same level on any particular axial image, but you'd want to select the images where you have that. And then if the right ventricle is more dilated than the left ventricle, then it's evidence of right heart strain. Also, the septum will be deviated towards the left heart in these cases. Another finding that we also see is not only is there dilatation of the right ventricle, but there's also dilatation of the right atrium. And notice that right atrial dilatation will also deviate the interatrial septum towards the left, decreasing the size of the left atrium. So why is this bad?
Decreased cardiac output.
How does that occur?
You decrease pulmonary venous return, which increases LV.
Yeah, so by you're diminishing the size of the left-sided chambers, so even the left atrium, so you're decreasing the amount of blood that can go through the left-sided chambers, and this is usually the cause of death. Usually the cause of death from pulmonary embolism is acute cor pulmonale, acute right heart failure. Okay? So that leads to decreased cardiac output, and then the decreased cardiac output can aggravate any ischemia, and then it causes the heart to fail even further. And so you get into this vicious cycle where the patient just goes downhill from the acute cor pulmonale to right ventricular failure. Okay? And then,
Imagine.
yeah.
Quick question. So, like, since we're talking about PE, on the article, it said that when we have Hounsfield units of 170 to 209 in the pulmonary arteries, that's like acceptable. But what do you say, because if it's greater than 210, that's fine, you know, but what do you say in those cases?
Well, okay, I mean, the most dangerous thing is a radiologist with a ruler or a measuring device, I think. You use your judgment, all right? How well can I evaluate the pulmonary arteries? What do I think, all right? I mean, those are numbers that they will use for studies because they have to have some kind of objective measurement of what's going to be an acceptable scan to include in their study, what's going to be suboptimal in terms of technique in the study. So that there's a need for numbers like that. But you know, when you're doing them and you see all kinds of cases coming through the ER, you have to use your judgment as to how well can I evaluate the pulmonary arteries. You know, at what point do I say, all right, there's no large central PE, but I can't tell you anything about the interlobars, the segmentals, or the subsegmentals. That's really what you need to determine. And the question is, do you see something that merits repeating the study? So that's the decision that you really need to make, right? Is this study so bad that I can't really rule out a significant large PE in this person, and we need to bring the person back for a repeat study? That's the decision that you need to make.
And like, what do you usually, do you have any tips on how to decide that, you know, like?
If there's no, well, usually you're doing it because the patient is symptomatic and they're trying to explain the symptoms, right? So the symptoms of PE, shortness of breath and all that stuff, usually they're large central PEs, right? Usually a single segmental or small segmental defects, usually are not going to result in, significant mortality, at least over the short term, okay? So if you can't evaluate the central vessels, then you probably should bring the patient back. And then we can do reformatted views showing you the right ventricle, left ventricle, septum, and you can see the clots too on the reformatted views. So in our next case here, so where's the PE in this case? Yeah, so we have clots in the right lower lobe segmental arteries. Anywhere else?
Upper.
There's clots in the interlobar on the right going into segmental branches, right? What about on the left side? So here you can see some filling defects in the left upper lobe, and as we follow there's another one there, as we follow the interlobar, there are clots in the interlobar also extending to the lower lobe vessels, right? So this is another patient with bilateral pulmonary embolism. These areas of peripheral ground glass opacity, what might that represent? Could be an infarct. Could it be anything else associated with PE? Pulmonary hemorrhage. So you can have pulmonary hemorrhage also associated with pulmonary embolism that can present as peripheral regions like that of ground glass opacity. Okay. And so again, reformatted views again show some dilatation of the right ventricle. There we can see the clots going down the interlobar artery in this case. Any PE here? Hello? Yes. Alan, can I call you back? I'm giving conference. Sure, I'll call you right back. Bye. So, where do we see the PE here?
Left interlobar.
Yeah, so the left interlobar extending down into segmental vessels on the left side. Okay, you can see those guys over there. Also some segmental clots there in the right lobe. Okay. And then here on the reformats, we can see the clots in the interlobar extending down. Here are the segmental branches there. There are clots on the left side. What about this one?
Left lower lobe segmental.
Yeah, so here, we look on the left side, here's the interlobar artery, follow that down, and we can see this segmental clot there in the left lower lobe. Okay? So that's down there. And what about this case?
Could be subsegmental left lower lobe, maybe.
Okay, so if we look carefully here, coming down, nice bright vessels. And then right there, that vessel looks different than the rest. So there's a small subsegmental clot here in the left lower lobe. Down there, this guy. So notice how it's different than all the rest of the vessels. Now sometimes, as you travel down on the P scan, depending on the degree of opacification, sometimes the contrast will peter out. So all the vessels look decreased. But if you see one vessel that's different than all the others, you have to be suspicious. And then this is where reformatted views can really be helpful, right? So here's your reformatted view showing you nicely that there is a big filling defect there within that subsegmental branch. So what happens if you miss this? Yeah, tending calls you over, but pretty much nothing. So it's actually controversial whether you need to treat a single subsegmental PE in a patient. Okay, so that's why you don't want to miss the big central PEs, and you probably won't. Any kind of decent CT scan, you're going to be able to pick up the big central PEs, especially if there's any right heart strain. Okay. Now the other thing is you also want to remember, we focus on the vessels in the lower lobes. You also want to remember to look carefully at the vessels in the upper lobes, because the lower lobes can be fine, okay? But when you're done looking at the lower lobes, you want to go back and look very carefully at the upper lobe vessels. Right? There's a clot here, a segmental clot in an upper lobe branch, okay? So you don't want to miss that. This guy here. And same thing can happen on the right side too. Right? So as we travel up, you want to make sure that you look at all the branches in the upper lobes also. Okay. So you don't want to miss. And again, reformatted views. If you have questions, go back and reform. I like to reformat views myself because the coronals, the standard coronals and sagittals that you get are not necessarily in the plane of the vessel. So if you do your own reformats at the workstation, you can usually work out if you're questioning any kind of small filling defect within the pulmonary vessel. Okay. So another case, not a very good quality study, and the question is there a PE there on the right side? See, it looks like as that right pulmonary artery is coming across, looks like there's a filling defect there. So what do you do to work that out? Is that a PE or not?
Look at the reformat.
What do you do?
Look at the reformat.
Yeah, so especially the coronal reformats. This is a very typical location to get a fake out on the axial images, because this is right where you have the bifurcation of that right pulmonary artery into the interlobar branch and the branch to the right upper lobe, the truncus anterior. And then right in here, you can have soft tissue, you can have lymph nodes, So when you take an axial cut through there, it almost looks like, or it does look like, there's a filling defect in the right pulmonary artery. Okay, so that's a common place where you can get fooled. And then looking at, you see these pulmonary arteries bilaterally? It looks like in the interlobar vessels here, looks like there are filling defects. Is that PE or is that something else? See?
It's another fake out.
So it's a fake out from what? First of all, why do you suspect it's a fake out and not a PE?
There's the P's that are like right at the branching point of the vessels.
Well, you can have a PE right in the interlobar artery, but you're right, PEs, typically can go across a branch point.
I mean, the direction of the filling defect is like it's streaky.
So real PEs, real clots tend to be lower in attenuation, right? This one, rather than a well-defined central filling defect, it almost looks like somebody is pulling a shade over the vessel. You see what I mean as you scroll down? It looks like somebody's pulling a shade over the vessel, right? So that's typical of an artifact. And so these guys here, right? So what that artifact represents in this case is stair-step artifact. And this is again where reformatted views can help you. So in a reformatted views, you see these streaks going across. So this is probably caused by beam hardening from the spine or other things that give you these kind of beam hardening artifacts. And so this is stair-step artifact. And so you can tell on the coronal views that this is not PE. PE does not look like that. But on the axial views, it does simulate a filling defect within the vessel. So that your reformatted views can be very helpful when you're trying to work out whether something is real or not. Okay? So here's another patient who has a CT for PE. What do we want to say about this? So what symptom do you think the patient presented with? What's the usual symptom? Chest pain or shortness of breath. Right? So what do we think is going on in this case? Does the patient have a PE? Yes or no? All right, we don't see a PE. Is there any other comments you want to make?
Signs of heart failure.
So what are the signs of heart failure?
The contrast going back to the liver.
The contrast is what?
Like reflux of the contrast to the liver. So poor heart function.
Well, not really that much. And with power injectors, especially with high injection rates, we can see some reflux of contrast into the IVC. But you said poor heart function.
Yeah.
Why do you think there's poor heart function?
There's cardiomegaly.
So the heart's a little on the big side. What else, though, tells you that the cardiac function is poor? There's no contrast filling the left atrium and left ventricle. So why is that?
So if you see this, like, it could have just been they scanned it early too, though, right?
Yeah, that's bullish.
Well, what's the protocol for scanning? How does it work? How do they know to scan at the right time?
Well, they put an ROI over it,
Over what?
main pulmonary.
Okay, main pulmonary artery. And then what happens?
Then the patient goes in.
What?
Then the patient goes in, right? Is that right?
You haven't quite explained to me what happens. So you put an ROI over the pulmonary artery, so what? What,
So you like.
first of all, what do we call that? What do we call that? Smart prep. So how does it work? You select a vessel of interest. That's how you're going to differentiate when you're going to time the scan for PE, for looking at the pulmonary arteries versus the aorta. If you want to look at the aorta, you're going to put your region of interest over the aorta. If you're doing an arterial phase scan, if you're doing it for the pulmonary artery, you put your region of interest over the pulmonary artery. Okay? And then what? How does the scanner know when to scan?
It's like the density, so it knows when the contrast pulse is
So,
in the area.
so as the contrast is going in at that one level, you're getting a series of low-dose axial images, and it's measuring, the software measures the attenuation within the region of interest, and once it's above a certain threshold, could be 150 ounce-per units, that triggers the scan to start, right? So once you hit that threshold, the scan will start on everybody, right? So then, you know, is it possible to scan too early?
I suppose not.
It shouldn't be, right? If you've hit that threshold, and assuming that the technologist put the region of interest, you know, over the pulmonary artery and not the superior vena cava. So what does it mean that there's no contrast on the left side of the heart, or very little? It means that the circulation time is prolonged. In most cases, when you're doing a PE scan, we do see contrast on the left side. So here, the circulation time is prolonged. It means the cardiac output is low, okay? And that's why you often get very good PE scans on these patients, because the circulation time is prolonged. It looks like the contrast sticks to the pulmonary arteries. It's in young patients that have a very fast circulation time, where the contrast seems like it actually shoots through the pulmonary arteries and is easily diluted by blood that comes up the inferior vena cava, where you tend to get poorer quality CT scans. In patients with failure, you tend to get very good opacification of pulmonary arteries. Right? And another finding here that also goes with failure as well. Yeah, there are pleural effusions. Okay, so this patient's symptoms were due to failure not pulmonary embolism. Now, we did tell them that on the chest radiograph, right? We read this chest radiograph from the ER that yes, cardiomegaly, vascular congestion, it looks like failure, but they did the PE scan anyway. It's not unusual here. For whatever reason, we do a lot of PE scans on patients in failure and patients with sickle cell disease. We will do PE scans on those patients, even though there's a readily available explanation for their symptoms. Also some patchy ground glass, and you can see the interlobular septal thickening there on the lung windows. Okay. What's abnormal on this chest radiograph? Is that a normal chest X-ray? So what do you, when you say hilar fullness, what are you telling us?
There's increased caliber of the vessels.
So are you saying there's lymphadenopathy, or are you saying the pulmonary artery is looking large?
The pulmonary is looking large.
Yeah, so the pulmonary artery is looking large, so what would do that?
Pulmonary hypertension.
Pulmonary hypertension, okay? And then here's the CT scan on this patient. So any abnormal findings so far?
Pulmonary arteries dilated.
Okay.
Pulmonary arteries very dilated. There's a big conglomerate of vessels in the right lower lobe.
What do you notice about the heart?
Right side bigger.
So what's wrong with the heart?
Right ventricle bigger than the left.
Yeah, so the right ventricle is dilated. Is this an acute or chronic problem? See, that right ventricle is going to be big, but is this an acute problem or a chronic problem? Why do you think it's chronic?
Because the muscles in the right atrium is so thick.
Not the right atrium, but the right ventricle.
Right ventricle.
Yeah. There's right ventricular hypertrophy, right? The anterior wall there is thickened. So the right ventricle is dilated from increased pressure. It's hypertrophy. So what's the cause of this then? So where do you see the chronic PE and how do you know it's chronic PE? So how do you know it's chronic PE? Yeah, so the filling defects, there are filling defects here as we come down the left and see that, but it's peripheral, it's eccentric. So there's an eccentric also here on the right. There are filling defects there within those lower lobe vessels, but they're eccentric filling defects, okay? And again, the reformatted views can be very helpful, showing you this eccentric filling defect here in the interlobar, there, and also some eccentric filling defects on the right side. So this is chronic pulmonary embolism, which has led to pulmonary hypertension in this patient, right? So the way you differentiate chronic from acute PE, you have central filling defects, chronic PE, you have peripheral filling defects, eccentric filling defects. With chronic PE, you can also have dilated right heart, but also right ventricular hypertrophy because of the elevated pressures in the right heart. So in the same patient, when we look at the lung windows, what do we call this? What is this? What are we seeing here?
Mosaic attenuation.
Yeah, mosaic attenuation. A more specific term is mosaic perfusion, right? So mosaic perfusion, in most cases, the most common cause of mosaic perfusion is what? Air trapping is the most common cause of mosaic perfusion, okay? But mosaic perfusion can also be caused by vascular disease like chronic pulmonary embolism. So we know it's mosaic perfusion because what? How do you know it's mosaic perfusion? Well, there's mosaic attenuation. That's the first thing. You have these areas of lucency, these areas that look almost like ground glass. But how do you know it's mosaic perfusion? What about the size of the vessels here?
There's pruning.
Yeah, the vessels, in the areas of decreased attenuation, the vessels are smaller, right? That's mosaic perfusion. So that means that the blood flow is shunted away from those areas. Now that can occur from air trapping, which is the most common cause, but it can also occur from vascular disease like chronic pulmonary embolism. Now how can you differentiate air trapping from chronic PE? If they can both give you mosaic perfusion. Well, first you look for the chronic PE, right? Big central vessels, chronic PE. And secondly, the distribution is somewhat different. With chronic PE, you have these larger areas of mosaic perfusion, whereas with air trapping, it tends to break down into secondary pulmonary lobules. And we'll see cases of that as we progress this year, okay? So that's an example of mosaic perfusion. More examples of chronic, sometimes this can be subtle. You can blow by it pretty easily on your axial images, right? So this over here is an eccentric filling defect in the right pulmonary artery. I mean, here it is extending there into the interlobar branch. By the way, there's another finding here. Does anybody see what it is? Well, I haven't shown you enough images to make that diagnosis. What's the other finding? Yes. Anything else? What about the heart?
Possibly a thrombus there?
Possibly a thrombus? Thrombus where? Right here in the left ventricular apex. There's this area of low attenuation that represents what? What'd you say it was? Secondary to what? What's the predisposing condition? AFib, thrombus in the left ventricle?
Neurothrombus post-MI.
Is there evidence that there has been an MI here? Well, you mentioned thinning of the interventricular septum, right? What do you notice about the apex? What is this stuff? Calcification. There's calcification in the apex of the ventricle, right? So there's an aneurysm, mature aneurysm there in the apex of the ventricle with calcification, and this is thrombus in the apex from a prior myocardial infarct. And this patient also has chronic PE, so multiple problems with this patient. And then here, again, on the axial images, you can easily overlook this. And then this is where, if you're questioning it, if you pick it up, your reformatted views can be very helpful. So if you do a nice sagittal reformatted view through that, now you can clearly see that there's an eccentric filling defect there within the right pulmonary artery, okay? That represents a chronic PE, okay? And then here, there's a reformat for the left ventricle. You can see the calcification, and the thrombus is actually more extensive than it appears on your axial images. Okay? So we also want to be on the lookout for chronic PEs. Other findings can be webs in addition to eccentric filling defects. Okay, we can also see webbing within the vessels, and the webbing represents recanalization, incomplete recanalization of the vessels can lead to webs within these vessels. And then again, if you're questioning it, a reformatted view can demonstrate this very nicely. Okay. What about this case? Any abnormality?
Maybe a filling defect on the left.
Okay, so we see a filling defect here on the left. So this patient has a filling defect is caused by pulmonary embolism. What other abnormality do you see? Well, what is this? Pleural effusion. What is this over here? Atelectasis. Or is anything strange looking about that? Jose? What's wrong here?
I mean, we have a part of that consolidation that's like perfusing, there's air in it.
So what's your interpretation then? Infarct, right. So look at so atelectatic lung does enhance. Okay, you can see the enhancement in the lung here, but for this part of the lung is not enhancing. And if you see that, you have to be suspicious about, in a patient who has pulmonary embolism, this represents an infarct. Okay, so that's an infarct here. Here it almost looks like cavitation, but it's not really cavitation. You can see on the lung windows it's not cavitary. Okay, so that's an infarct. More extensive. Here's a patient with a more extensive infarct here. You can see the PE on the reformatted view. But notice that this lung tissue here does not enhance nearly as much as the true atelectasis. So this represents infarct. Okay? And then here too, even though it's not a PE scan, this patient has these areas of lucency here, okay? Almost looks like cavitation, but on the lung windows, you can see that it's not cavitary, right? So this has been called a reverse halo sign. So the reverse halo sign is also associated with infarcts. So when a patient comes back for a PE scan, we can see that there are filling defects here. There is a pulmonary embolism, and then this area does represent infarct. Notice it's not enhancing as much as the really atelectatic regions of the lung. Yeah. Well, we have another example here of a reverse halo sign. So it's not a specific finding. There are many, there are numerous things that can give you a reverse halo sign. But reverse halo sign can also occur with infarct and pulmonary embolism. So what happens is we have this area of consolidation, but the central portion of it is more lucent relative to the periphery. That's called a reverse halo sign. And it is associated with infarct. Notice on your pulmonary phase scan here, you see the PE, but you also notice that the lung tissue is not enhancing. That's an infarct with a reverse halo sign, okay? And then here, 1 month later, you can see how these infarcts can resolve. They kind of resolve from the outside in. It's called the ice cube sign, the way these infarcts can resolve. Okay? So the reverse halo sign is associated with infarction. Does that answer your question? Yeah, that means there's ground glass inside and consolidation outside, as opposed to the halo sign where there's consolidation inside and the ground glass is the halo around it. Okay? And so here's an example of somebody with a non-contrast CT who had somewhat, these kind of reverse halo signs and turned out to be infarcts from PE. Comes back for a PE scan, and there's these segmental clots. And so what we're looking at is actual infarcts with the reverse halo sign. Okay? So that can be associated with PE. All right, so we'll stop there for today.